Dr. Agaga is an anesthesiologist and a member of the Open Oximetry team. She is Director of Safety and Quality at SmileTrain and also consults with the Lifebox Foundation. She's faculty lecturer at Makerere University in Kampala, Uganda, and a longtime collaborator with the team here at UCSF. She's based in Kampala, Uganda, and for many years has been at the forefront of advocating for safe surgery and anesthesia in her country, as well as many others as part of the Association of Anesthesiologists of Uganda and many other groups. We're really lucky to have her joining us today at this late hour in Uganda. Dr. Agaga, over to you.
Thank you, Mike. I hope I can be heard. I will not go through my intro again, but thank you for the kind intro. As Mike said, I serve as a Director of Safety and Quality for SmileTrain, and I consult with the Lifebox Foundation as the anesthesia advisor. So my job today is basically talking about challenges of pulse oximetry in the real world. And while I know we're here to talk about, skin pigmentation and regulation and guidance around that, I just wanted to make sure that we all go back to some of the problems that are still lurking in some parts of our world. This is a paper that was published in 2010 that was basically estimating how many pulse oximeters we have globally. And the data was not great. Over 70,000 operating rooms worldwide then had no pulse oximeter at all. Obviously, with the pandemic, that may have changed a little bit, but we do not know for sure what the discrepancy in terms of distribution of pulse oximetry is. So some of the things that I've heard being talked about are prohibitive costs. So for the low and middle income countries, the cost of the pulse oximeter is prohibitive in itself. And I've heard my colleagues talk about, the wellness pulse oximeters that don't have to go through all this stringent, testing before they are rolled out. Sometimes because of the prohibitive cost of the ones that are tested, we end up having to buy the ones that are wellness ones and use them as pulse oximeters in the clinical space. But the other thing is, even after the pulse oximeters have been bought, distributing them is becoming a challenge. There's so much regulation around distribution, but also the cost of clearing, the costs of taxes into the different countries is extremely prohibitive, and that makes access really difficult. I wanted to put it in context here. I went around asking different anesthesiologists in Kampala what they thought their challenges with pulse oximetry were. And one of the things that was a recurrent theme was access to appropriately sized probes. So even when we have access to a pulse oximeter, for example, on your left, we have a child who was operated last week. She was only 3 weeks old, but you can see the size of the pulse oximeter probe on her finger. The child on the left was 4 years old. One, you can see the size of the pulse oximeter on his finger, but also it's being held together by an elastic band from a glove, because one, it's too big, but it's also faulty. If you don't have that band on, then the probe will fall off. So as you can see, these are some of the real world challenges that we're still dealing with as recent as last week. Another issue was durability. Basically, the resounding situation was these pulse oximeters are not robust enough for the system that we work in the low and middle income countries. These are 2 pulse oximeter probes, and they're cabled, and as you can see, they're being held together by strapping. And I hate to say this, but this is in some of the more affluent parts of my country. So you can only imagine what happens in those other places. But also, as we all know, the operating room environment is quite busy. And because of that, there's so many moving parts that could cause a bit of damage to that. We also have maintenance challenges. As you know, sometimes we get donations of different pieces of equipment, pulse oximeters inclusive, and sometimes when they break down or they require maintenance, the biomedical engineers do not have the training or the experience to ensure that they're able to maintain or repair these pulse oximeters. But also because, again, the nature of the equipment is it is a donation, sometimes we don't even have the spare parts to take care of those. And importing them is a whole different cost, which becomes prohibitive in itself. The other challenge is training. While in the cities, we have anesthesiologists and anesthesia providers who are more exposed. While the pulse oximeter is a valuable tool, it's either one, misused, and I'll put that in context in a few minutes, but also underutilized. So when I say misused, it's because people put a pulse oximeter on a finger and barely have a tracing but have a number on the screen, and will basically write that number down and say the patient was saturating okay, although there was no proper wave. And if you know the physics of pulse oximetry, you know that you need that wave to work appropriately, and you need to have an appropriate wave before you can actually trust to an extent the reading. In terms of underutilization, we all know that the plethysmogram is something that you can use aside from seeing the patient's pulse and what their oxygen levels are. You can also use it to deal with fluid balance and so many other things. But unfortunately, because we do not have enough access to training and we have not been able to train the users of pulse oximeters as much as we would like to, these modalities are underutilized. So you have a great pulse oximeter on a beautiful screen telling you all this information that you either do not know, you don't even know that it's there, or you do not know how to interpret and intervene accordingly. One of the other issues is reliability in extreme conditions. We have some of the sickest patients worldwide. So we have patients in septic shock, we have patients in hypovolemic shock. And of course, because of that and the way the pulse oximeter works, we're not able to get accurate readings because again, the machines are not as reliable as they should be. Also, in the process of transportation, apart from the fact that we don't have proper transport monitors readily available, during movement, sometimes you will get a reading, but the reading is left to the discretion of the provider to interpret, which may not be as accurate as we would like it to be and as reliable as we would like it to be. So down to the issue of skin pigmentation, which I believe is one of the biggest reasons why we're here. I believe that one, we do not know yet what we don't know. I know that this is something that has been studied for years, but especially in people with darker pigmented skins, we are not 100% sure of how big the extent of the issue is. And so I think there's need to clearly define how big the issue is, and then start to curate solutions towards that. However, this was one of my last slides because while skin pigmentation and the discrepancy in reliability of results where skin pigmentation is concerned is a big problem, in the LMICs, we still have issues that are easily solvable, but are still big issues. And so what I would like to do is to urge all of us in this room, we're all stakeholders in this. We all know that, especially after the pandemic, that oximeters are essential tools to help us improve the safety of patients. But I believe that access, reliability, and performance require attention. And I put access in red because I believe if we don't have an oximeter to work with in the first place, then us regulating a lot of these other things may not be as productive as we would want it to be. As I already said, oximeter bias in dark skin has been flagged, but it's unclear how far-reaching the problem is. And I'm glad that there are people in this room and who are going to be here with us over the course of the next 2 days discussing what this means for us in terms of how far the problem is, what can we do to find out how big the problem is, and that kind of thing. I know we have some of the regulators in the room, and I would just like for all of us, while we discuss all the regulation around skin pigmentation, to be cognizant of the challenges that are available with that we have with access. If we tighten regulations without thinking about all these problems that I've spoken about, especially in terms of getting these machines into the countries, we may actually end up causing a bigger problem than we wanted to cause and solve the problem for some people, but eventually widen the health equity gap. Over to you, Mike, and thank you for listening to me.
Dr. Gaga, thank you so much for taking the time to join us. Our next speaker is going to be Dr. Michael Schoding. Dr. Schoding while you're sharing your slides, I'll give a quick introduction. Dr. Schoding, I think almost everybody on this call is going to be well familiar with your research from 2020. Dr. Schoding is an associate professor of internal medicine in the Division of Pulmonary and Critical Care at the University of Michigan. His research focuses on developing new computational tools to support diagnosis and identify optimal treatment strategies for patients with lung disease. He also studies care delivery and outcomes of patients with lung disease, and of course, published a quite influential paper that has led to a lot of the reasons why we're here in this room. Dr. Schoding, over to you. Thanks for joining us.
Well, thanks for inviting me, and I hope you can hear me. I'm actually on clinical service, which doesn't happen to me that often because I spend a lot of my time doing research, but this is the reason why I'm sort of holed up in a hospital call room, and I hope there isn't a lot of loud interruptive noises. But, you know, part of the story here for me is that while I am a researcher and I'm pretty thoughtful about my research, I didn't really have any knowledge of pulse oximeter research or prior work on accuracy issues with pulse oximeters. And I think that speaks to one of the larger issues that was already discussed, which is, you know, although some of the issues with accuracy and the imperfections of pulse oximeters are known in some communities, they're not broadly known. And myself, as a pulmonary and critical care faculty at University of Michigan, really didn't know them. And we've really changed over years how pulse oximeters have been used in practice. And perhaps in some respects, we got caught flat-footed by the ways pulse oximeters are being used versus the ways they've been tested for safety and effectiveness. So this story started for me at the beginning of COVID-19. I, like many others, were on the front lines caring for a lot of patients, and we happened to get a big surge of patients from the greater Detroit area in Ann Arbor, Michigan. And so I was caring for more patients with racial diversity and dark skin than typical. And honestly, we just saw anecdotally patients on the ventilator who were having pulse oximeters with normal levels and then arterial blood gases that were low, and really didn't know what to make of them. And that's what motivated our whole study. And so we did something quite a bit different than people in the past have done. We used this data source that many people took tremendous issue with because of its significant flaws and inaccuracies. But, you know, as an outsider, I didn't know any better. I just did it anyway. And so we used electronic health record data. We used self-reports of black and white, which is clearly imperfect, but that's what we had available. And we looked at pulse oximeter readings and arterial blood gases within 10 minutes. And 10 minutes is a heck of a long time. I fully admit that. But we ended up having lots of data, right? Because there's lots of routinely collected data in practice now. And so we leveraged the size of the data in a way that I don't think had been done as much in the past. And so we plotted this figure which showed this really clear difference in performance when you look at what the saturation range is reported on the pulse oximeter and what the arterial saturation is. You can see a lot of things here that are kind of sort of profound, like pretty interesting. Like, so when the pulse oximeter is reading 92, the range of possible arterial oxygen saturation is pretty wide. So again, we use these devices in practice in a way, thinking and hoping that the pulse oximeter is quite accurate, and maybe they're not always accurate. Some of the issue here is, you know, quite frankly, that we waited a few minutes before getting the arterial blood gas, and so there's going to be some shift, there's going to be some change. Probably most of the patients in this study were pretty sick. Nonetheless, it's still important to know how much dynamic changes there are in the patients who are pretty sick. And we did this thing which we called occult hypoxemia. It was sort of very different than what people had done before. And it was really motivated by me as a clinical doctor. Like, how do I use the pulse oximeter? What do I want to know? So when I'm caring for patients in the ICU, I try to titrate oxygen to a fairly narrow range, 92 to 96%. Too high, I'm worried about hyperoxia. I'm giving too much oxygen, which could be harmful. Too low, obviously we're worried about low oxygen levels, which could be harmful. So we target this tight range of 92 to 96%. And so then I was like, okay, as a clinician, I'm targeting this tight range. Like, I want to know how often the pulse oximeter is tremendously wrong enough that I would change how I care for a patient. And so that's the reason why we set this SaO2 target of less than 88. How often do I think it's normal? Yet it's actually way off. And so we found this to not occur very frequently in white patients, and frankly, not occur that frequently in Black patients, 11% versus 3%. But the difference, like 3 times as high, is like, whoa, that's way different. And then, as already been reported, we designed this evaluation to align with the fact that, like, if this missed level of oxygen, I had known about it, I would have changed my care. And several follow-up studies have shown that, yes, like, care is probably affected because of these differences. One of the main and reasonable critiques of this so-called occult hypoxemia measure is that it can be influenced by the underlying prevalence of low oxygen. So if you have 2 populations of patients, one who comes in and has just a lower distribution of oxygen, then you're going to get more missed low oxygen because there's just more low oxygen to potentially miss. And so the one critique that has been raised about this is, well, this could be affected by difference in prevalence. But in the matter of course of business, it turns out that, like, they're in general, like, Black patients or darkly pigmented patients don't have like a lower prevalence of, or a higher prevalence of low oxygen at baseline. So if they do have a higher prevalence of low oxygen, it's probably because we're just not giving them enough oxygen in the first place. And that has been shown in other studies. So I think this sort of concern about this measure being flawed because of the sort of the difference in prevalence, I think there's less concern there than is actually the case. And one thing I will say here is that in this study, we did this other measure called the area under the receiver operating characteristic curve, right? And that is not impacted by prevalence. So, this occult hypoxemia measure that's impacted by prevalence, this AUROC that's not impacted by prevalence, we still saw the big difference. And then obviously, since this study, it's been repeated a lot. I'll just focus a bit here on this slide because I know you guys are sort of thinking about standards. I would, the lots of laboratory studies have shown that there has been differences in accuracy based on skin pigment, but the differences weren't that large, such that maybe it wasn't really impacting patient care. I did this analysis just to understand a little bit better, like, what could be actually going on. So this represents the distribution of possible arterial oxygen saturation readings in a patient whose pulse oximeter is reading at 92%. And so, we have some noise in our measurement. We all get that. And so how does that noise impact readings in practice? And what I'm showing you here is that we're going to always have tails of our distributions, right? Like, we're always going to have sort of a part of the readings that are a bit more inaccurate because there's a distribution of accuracy here. But what I'm trying to show you here is that, like, if that distribution shifts a little bit, the tail changes a lot. So if we lose precision by 0.5% and increase bias by 1%, we can see that our chances of missing low oxygen when the pulse oximeter is reading 92% drops or increases dramatically. So a small increase in the mean and the variance can increase the tail in a way that that can be clinically important. And so that's really why I think that this finding that we found can be explained even if pulse oximeters, there is a difference in accuracy, but maybe it feels like it's not that much. Well, the problem is at the tails. And so, when you guys are thinking about sort of changes to the standard, I really hope that you recognize the fact that the problem is at the tails. And, if everyone sort of appreciates that there's a bit of noise with the pulse oximeter, fine. But if the bit of noise is quite a bit more accurate in a group of patients that, has experienced structural racial bias for generations, that feels like it's a really big problem. So, there was tons of limitations to our work. I think the reason why people sort of believed it was fundamentally because this wasn't the first time this was ever shown. This was just shown in a different way. We had lots of data to analyze that was different from the past, but there was several significant limitations to our analysis, which I think have been described in detail in many places, including by manufacturers. But I'm sort of grateful for the fact that, like, despite those limitations, people, you in this room and others, have sort of picked up the charge to really take this problem seriously and move forward. So I'll just close by thinking about some things that I think are essential moving forward. I think, like, number one, there has to be some effort to report pulse oximetry across some meaningful groups. Is it racial groups? I appreciate that, race is a social construct, not a biologic construct. So if the underlying mechanism here is skin pigment, it has to be by skin pigment. I hope that I'm sort of showing you that, like, in clinical practice, in pulmonary medicine, in the hospital, like, we use pulse oximeters in a way that's sort of different from when they were first evaluated and our sort of current standards are sort of aligned with. That's maybe a problem, but, like, in practice, like, it's hard. It's like, are we going to change practice because pulse oximeters are sort of less accurate than we all think, versus can we increase the accuracy standards of pulse oximeters? I think we have to meet somewhere in the middle. I'm not an expert on desaturation tests, but my sense is, what we're doing in the lab setting isn't really fully reflective of what's happening in real world practice. So I would really encourage ensuring that laboratory practice aligns with real world practice. And then I think there's, like, a clear value in collection of routine pulse mark surveillance setting data to really understand if what we're seeing in the lab is translating to what we're seeing in practice. So that's all I had to share. I really just want to thank everyone for taking up this charge. I will try to stick around for questions, but I may be called back towards clinical service. So thanks again.
Thanks very much, Michael. Appreciate it. We have one comment. Dr. Benton, I don't know if you want to expand on your comment in the chat. And while we're doing that, we'll go ahead and pull up slides for our next speaker, Dr. Hendrickson. Dr. Benton, do you want to expand on your comment in the chat?
I can just address my comment was actually about the limitation being the self-reporting of race. I think, when people are using that as a kind of way to talk about the limitations, it often comes with the baggage of Blackness being a comorbidity itself, rather than being associated with certain kinds of comorbidities that might shape oxygen readings, oxygen saturation. So it's just, I think of that as, when I hear that as a limitation, I hesitate, I pause. So that was my only comment.
I appreciate that because, it's their self-report, right? Like, so it means something, assuming it's the people actually reported it rather than someone else sort of self-reported it for them. So it still feels like it's a real thing,
Yeah, it's culturally and socially meaningful, absolutely.
Yeah, exactly.
Thank you very much for that comment. And for those who don't know Dr. Benton will be speaking tomorrow. She's a cultural anthropologist. Thanks for joining and thanks for the comments. We're going to move on to our next speaker, Dr. Carolyn Hendrickson. Dr. Hendrickson is a pulmonary and critical care medicine subspecialist with expertise and research focused on acute lung injury and acute respiratory distress. She's the medical director of the medical intensive care unit here at the Zuckerberg San Francisco General Hospital, where she helped to lead much of the COVID-19 response in the ICUs. She also helps lead multiple clinical trials, including the Open Oximetry Equiax study of pulse oximeter performance in adult critically ill patients. So without further ado, thanks for joining us. Over to you.
All right, thanks for having me here. I have no disclosures. I do want to keep these broad concepts in mind when we're touring the slides that reflect the work that's ongoing at our hospital. I'm gonna just quickly blow through the study design and kind of the research environment just to frame some of the data I'm gonna show you at the end. And I wanna leave time to really look at some of our distribution graphs together. And I'm keeping time. So forgive me if I go quickly. I would be happy to share these slides with anyone or answer questions about the research study if you're thinking of designing something similar at your institution. We've got some barriers to data capture that resulted in missing this, which will be important to some of the data analyses presentations that are coming up later today. And then I do want to share with you the distribution of some key outcomes and covariates or confounders that we've been tracking. Although we have not analyzed our data, we're just midway through data collection, so this is not going to be a full analysis. And then I want to call attention to questions that will come up about generalizability of the findings, power, and testing relevant causal pathways in these important questions. So our planned analysis, we're using the predictor of skin pigment, not race. And the outcome is oximeter errors or bias. The covariates that we're studying are many, and I actually am going to tell you that I don't know which of them are confounders, I don't know which are mediators, and I don't know which ones are effect modifiers. And so I have some ideas, but I'm very receptive to your suggestions as well. So we're going to compare pulse oximeter errors across skin pigment categories. There's a lot of important details in that plan that are going to be fleshed out later. And the primary analysis that we're going to focus on is a skin pigmentation in the distal phalanx as the site predictor of interest, because that's where most of our pulse oximeter probes are in the hospital. We're recording data on perfusion index, vasopressor use, and other important comorbidities in these patients. And of course, we are hoping to facilitate a lot of exploratory and secondary analyses that might inform future studies as well. So this is our hospital. It's tiny but mighty. We are the level 1 trauma center, and we're also the safety net hospital. We are all UCSF faculty, and we care for underserved populations in San Francisco. And because of structural racism, we care for more people of color than other hospitals in the area. We have 58 licensed ICU beds and average about 115 medical ICU admissions each month. We are enrolling adults who have arterial lines in place. This is a minimal risk study, and we exclude populations who would be at high risk for coercion, like patients in custody of law enforcement officials are not eligible to participate. This is a poster that we have made that we stick all over the ICU, including on the ventilators, to try to recruit patients into our study. Here's an image of it taped onto a ventilator. So what we do is we screen everybody who comes into the ICU that has an arterial line in all of like the trauma, neuro, and medical ICUs. And we sort an epic list using arterial line as the key feature for sorting. And then our CRCs are really wonderful and collaborative, and so are our colleagues in RT and respiratory therapy and nursing. And everybody sort of walks around and looks for patients who could be eligible to participate. These are some of our clinical staff who are eager participants, and they will actually call us proactively to say, "Hey, I have a patient who has an art line. I'm gonna draw gas. Do you want to come observe?" And here we have Celine, who is wearing her Equiox cap, and she's sitting with a couple of respiratory therapists who she rounded with in the morning to make sure she knew when blood gases were planned for. This is our rolly cart. We roll around the ICU. That back panel there has language appropriate consent forms for people to be able to read information in their preferred languages. And we have 24-hour access to medical interpreters to have inclusive enrollment. This is our own blood gas analyzer that we have parked in a utility room in the ICU so we can run our own gases quickly. And then just for those of you who are interested in this, all of our devices in the hospital are Masimo compatible. We use a Philips monitor. We've been enrolling for 7 months, and we have 143 fully consented subjects enrolled. We anticipate enrolling about 250 by the summer of 2023. We've collected 375 blood gas samples. These are directly observed by study personnel who are at the bedside recording the tracings, the stability of the tracing, and also any administration of oxygen and vasopressors or medications of use. I want to call attention to how hard it is to get samples less than 90%. These patients are being cared for by a very attentive medical team. They're not going to let them desat and hang out in the low 80s. Sometimes that happens for medical problems that we can't rescue right away, but these are transient events and they're very hard to capture. Our cohort demographics to date, it's a population that I think is familiar to physicians practicing in California. Notably, the BMI of our patients is lower than nationwide. We have predominantly men enrolled in our cohort to date, and that actually is reflective of our ICU population. Because we are a trauma center, we skew towards more men in the ICU. So here is the study subject self-identified race. You can see that most of our patients, or the biggest category, are white, 25%. We have 24% Asian and 18% Black or African American. And then we have a distribution that's pretty small in other categories. Other means that there was no self-report in the chart, or it might be that none of these categories are adequate to describe someone who comes from a background that includes many races. Here's the ethnicity breakdown. We have 16% Latinx patients in this population, which is reflective of the population we serve at San Francisco General, although lower than national prevalence of Latino people in the United States. Most of our patients who have art lines are mechanically ventilated. This includes non-invasive, but some of them are just, there without nasal can or without oxygen supplementation, maybe for blood pressure monitoring. And then I'm not going to show you any of these covariates, but I do want to tell you that we are collecting a lot of information in the chart of these patients that will allow us to ask questions about, if we do see differences in pulse oximeter errors, are there mediators or mechanisms we could test to understand why patients have different values? Is it skin pigment, or is it something else? Or is it a confluence of these things? Data collection, I'm going to just skim through very quickly and tell you that we're using 2 colorimeters, multiple skin scales, and calipers to measure finger diameters. We take skin color assessments at multiple sites, and this will be presented by other speakers at this conference. These are the devices that we're using. And I just put this photo in here to show you that there is missingness in the data. This patient has a central line bandage near their ear, and this is someone who is awake and very happy to participate in photography. But when you try to put this device on the ear, you're like squishing it forward and like trying to shove it between the pillows of the bed. A lot of our patients have C-collars on for spine injuries. They might be casted, they have burns, they have wounds, they have skin breakdown. So we can't get all of the data from all of the points in a real world study. As I mentioned before, the stability of oxygen saturation is transient and it's hard to capture. And when we're running into a room, when someone is desatting, it is almost impossible to get the other research devices on the finger beyond the things that are already in place for clinical care. So while we would like to test a variety of devices, we really need to work out how we're going to capture that data, especially during these transient episodes. And I think the key to the success would be more study personnel and more portable devices. But as of now, we capture about 1/3 to 50% of the samples we get our research devices on, in addition to the hospital monitoring devices. And then Caroline here is dressed up in Contact precaution isolation. It's just one additional barrier that makes it hard to get into the room to get the readings when we need them. So here is an imperfect breakdown of enrollment to date with a sort of arbitrary division of the von Luschen scale into 6 categories. You can see that most of our patients are represented in the middle categories and very few at the most lightest and darkest pigmentation scales. I want to point out here that these are the SpO2 values at the time of ABG collection, and you can see they're skewed into the range that you would want your patient to be in when you're taking care of them. And that they're this range, which Dr. Schoding mentioned as being of high interest to clinicians, where you want to be sure that your patient is okay, but there's some uncertainty that you might change your treatment if the reading were actually reflecting a lower oxygen saturation on the arterial blood gas. Here's our scatter plot. I'm calling attention here to, again, the low number of observations that are in saturation ranges that would be of highest interest to clinicians. And that's namely in the low 90s to mid 80s. If someone's stat is in the low 80s, you're probably going to do something about it and don't need to get a blood gas. But if they're 92, you really want to make sure that they're 92 and not 86. I just made this spline here to say we also don't know what the shape of the relationship is between the SaO2 and the SpO2 values. Maybe it's linear at the higher levels, maybe it plummets off at the lower levels. I think there's a lot of questions that we have about how to model these data to answer the questions that patients and doctors want to know. This one is really food for thought. So in the lab, I don't do the pulse ox, the controlled studies, but my understanding is that the perfusion index is generally above 2, and you guys heat the hands of your patients to make that happen. I want to point out that half of our observations are below that in the hospital. And there's a reason for that. These people are sick and have arterial lines and they're in the ICU, so they have abnormal perfusion. So I think this is an oversimplified way to ask the question of what is going on here. Is skin pigment just a better way to describe differences in race that we, with the retrospective data observing pulse oximeter errors? Or is there another pathway that doesn't work through skin pigment? Or is it a little bit messier, something like this, where skin pigment is associated with structural racism and differences in chronic comorbidities, differential care, difference in perfusion and tissue edema. With this arrow, I am implying that these are effects that people suffer because of the way we have treated them differently and given them differential care and different access to resources. I'm not suggesting that there is a genetic reason for differences in chronic comorbidities. And so I invite you to help us think about how to look at our data to really understand the problem. I want to understand if skin pigment is driving pulse oximeter errors, but I don't want to be married to that very oversimplified working model. So that's it for me. I'm happy to take questions, and please pull me aside if you want to talk about any study design or questions you have about these data.
Thanks very much, Dr. Hendrickson. Appreciate that. Next up, we're going to hear from a team at Stanford, Dr. Conrad and Dr. Taneja. If you want to start pulling up your slides, I'll briefly introduce you. Dr. Conrad is, can you hear us, Dr. Conrad?
Yes, I can hear you.
Okay, great. If you have slides, if you want to go ahead and start sharing your screen, great. So Dr. Conrad is currently Chief Resident of Pediatric Cardiology at Stanford. She has a passion for population health and health disparities. She completed a combined residency in internal medicine and pediatrics. And her research interests include health disparities She's currently a co-investigator on the FDA-funded study investigating the accuracy of pulse oximetry in children with increased skin pigmentation. She's also joined by Dr. Rohan Taneja, a research coordinator for the Pulse Ox study at Lucile Packard Children's Hospital that I just alluded to. He supported the commercialization and clinical research of cardiovascular devices, including heart valves at Medtronic from 2007 to 2019, and also has an MBA, and will be joining us to share some experiences as well. Dr. Conrad and Dr. Taneja, over to you. Thanks for joining.
Thank you. Thank you for allowing us to share our information and our data. All right, we have no disclosures. Our study is funded through the FDA through the UCSF Stanford CERC collaboration. So this is our agenda for today of what we'll go over for our presentation. This is our collaborators of all of our team with UCSF, our Stanford team, and the FDA. This is our Stanford team, which includes a diverse group of faculty, including cardiac anesthesia, ICU, PACT, our heart failure, as well as the cath lab. So just as a reminder of our specific aims for our study, and it is to test the hypothesis that among children less than 21 years of age, that the mean bias in FDA-cleared pulse oximeters increases with increased skin pigmentation as measured objectively and subjectively through these scales. And then secondarily, it is to test the hypothesis that the mean bias in FDA-cleared pulse oximeters is mitigated, if not eliminated, after adjusting for the perfusion index. So for our study design, it's a single center prospective clinical trial. It includes children less than 21 years of age who already have existing arterial access. We've excluded some children with anemia, no pulsatility, as well as those with methemoglobinemia. And we are objectively and subjectively measuring the skin pigmentation. Subjectively, we're using the Fitzpatrick, Von Luschen, and Monk scales. Objectively, we're doing it via colorimetry using the Konica and Delphin colorimeters at multiple locations, as has been discussed with other presentations. And then our oxygen saturation is measured by SpO2 using the Masimo Rad-7 device, as well as through the SaO2 is measured through a co-oximetry. And we are aiming to recruit 154 patients. And this is based off of the assumption of an interclass correlation coefficient of 0.15. So for some baseline characteristics of our patient population, we have enrolled patients as young as 1 week of age and as old as 18, with the median being about 11 months old. This is a distribution of us having usually younger, more infants and school-age children. We have about 37% female, about 50% is of Hispanic ethnicity. When you break it down to the self-reported race, while it appears as though we have no Black patients, that's not necessarily true. Under our other, which is about 44%, some of our patients who are of Hispanic ethnicity, as well as those who are Black, have sometimes selected as other, or biracial, they have selected other. And then we also have recruited some Asian as well. And then also of note is that about 40% of our populations is chronically hypoxic, having SATs within the 80 to 89 range, about 30%, and then about 10% having SATs less than 80% at baseline. So with regards to our recruitment and our skin pigmentation, let me see if I can use a pointer. Can y'all see my pointer? Here we have recruited more likely on the lighter end of our scales, with pale and white skin being a majority. And then we have recruited also on the other end of the spectrum through the Fitzpatrick and the Monk scales as well. And we'll be making more efforts to recruit heavily on the other end of our spectrum. This right here for our preliminary data is the correlation between SpO2 and SaO2. Here we have a correlation coefficient of about 0.79, and this is of 19 of our 26 subjects thus far, with about 38 paired observations. So there's been quite a couple of things that we've learned thus far in conducting our study in real life. And one of the first things that we came across is advances in technology potentially compromising the validity of our study. So during our enrollment process, we've had the release of the Masimo Radical 7, which has reported improved accuracy at low perfusion. However, our institution had yet to convert to this new technology. And we didn't want to have that jeopardize our validity by using outdated pulse oximeters. So we worked with Masimo to bring the new sensors online in expedited timeline. We offered an in-service training on the new technology, and we have been rolling out the Masimo Rad 7 throughout our heart center, starting principally at the places where we're heavily recruiting patients, which is the CVICU and the ORs and the cath lab. Our second challenge is pigment assessment. And ultimately, like a gold standard for skin pigmentation assessment doesn't really exist. And also for children, it can take up to about 1 hour per patient to assess pigment across multiple body locations. And finally, colorimeters were never designed with children in mind, and there's a sizing mismatch. So to kind of alleviate some of these, we've been using multiple scales and colorimeters simultaneously. So we're using the Fitzpatrick, the Monk, as well as the von Luschken. And then we've simplified our protocol based on some of our incoming data. And thus far, like we've seen that there's maybe not as much of a difference between certain sections of dorsal index finger and the hand. So we dropped some of the measurements. Also, given that the colorimeters has been shown in other presentations are pretty large, and so we had to include preterm infants in our ineligibility criteria due to the risk of hypothermia outside of that isolate. An additional challenge we've had is reducing the impact of pre-analytical factors of SaO2 measurement, like travel to the lab, sample sitting on the lab bench. So what we've done instead is we use a bedside blood gas monitor and co-oximeter that is validated and reduces pre-analytical errors related to specimen shipment and handling. And we were able to analyze our blood samples in about less than a minute after the blood draw. Another thing is that we've learned that there's some dynamic changes in oxygen saturations in the operation room. And this is where we originally anticipated significantly enrolling patients. Therefore, we have shifted our enrollment from the OR to the CVICU, where enrollment has been a lot easier and saturations have been more stable to allow for steady state assessment. But in that presented a new challenge in that in the ICU, children are often sedated. Parents also have jobs. They also have other kids that they're caring for, and they're not always at the bedside. So we had to go back and get IRB approval to do remote and e-consent for when patients are not at the bedside so that we can continue to recruit patients. Another challenge is parent anxiety that sometimes can hinder our enrollment. There's been a perception of the amount of blood draws that are gone and the quantity of blood. There's increased anxiety with the new knowledge of a possible pulse oximetry inaccuracy. So frequently now parents, when alarms are already going off and they have a lot of PTSD in the CVICU, now they have a new added concern from the study of, is this pulse oximeter actually accurate on my child? And then there's also possible mistrust of institutional research, as some of our patients who have declined have all been minorities. So to mitigate some of this, we've been using syringe and spoon props to help parents understand the quantity of blood. We've done strategic timing of approaching the parents and soliciting the help of our bedside nurses who form great relationships with the parents and families. And then we're also working with consideration of minority concordance with recruitment and consent. I think it froze. My apologies. Give me 1 second. There we go. Finally, we also deal with child anxiety hindering data collection. There's a lot of movement and motion artifact. Children are very active, as they should be, and they move a lot. Additionally, there's a little bit of PTSD from multiple procedures. This is exacerbated by the presence of gloves and surgical caps. And then again, some of the colorimeter size can be intimidating. As you can see here, just the perception of how small an infant finger is and how big that is the Konica colorimeter is, to kind of put that in perspective. So some of the things that we've done is we've removed intimidating PPE, which sometimes requires a longer scrub time and sterilization times. We've also involved our child life in reducing the fear around colorimeters as well. So in conclusion, we've begun enrolling and anticipate we are on track to complete 154 enrollment by July of 2023. We recognize that we will need to increase our sampling of non-white subjects while still relatively early in our study. And finally, but most importantly, we've learned that protocols from adult clinical trials cannot be directly transferred to pediatric populations. This population presents new challenges, and we are constantly modifying the protocol as we learn. And I'd like to thank you for this time. I'd like to give special acknowledgement to our UCSF colleagues, the FDA for making this study possible, Massimo for assisting us with updating our pulse oximeters as well, Dr. Monk for meeting with us and discussing the scales, and all the countless others, if I'm forgetting anyone, who have helped us in making our study success thus far. Thank you so much. Oh, and I'm sorry, I just realized that I was invisible this entire time. Sorry, you guys, let me make myself visible. But thank you.
Thanks very much, Dr. Conrad. So
Here I am.
a couple of thanks, Dr. Conrad. There is a question in the chat. I was wondering maybe you could quickly address here. So from Josh Pfeffer, what are the recruiting targets for this study, particularly for very dark-skinned subjects? Are they based on objective or subjective methods?
Our targets are currently, if I'm not mistaken, are based off of the von Luschkin scale and based off of recruiting equally in each of the 4 groups.
Thanks very much. And then from William Williamson, how will you adjust for outliers? Any comment on that briefly? And we will have a comment, or rather a session on statistics this afternoon, but we can come back to that. But Dr. Conrad, I don't know if you want to briefly comment on how you might adjust for outliers.
I'm going to defer that one to our protocol director, because we were actually having some of those discussions earlier this morning as we were kind of reviewing our data and also discussing with the FDA. So I can defer that to them. And I also didn't include some of our perfusion index data as well. I know that's not an answer to this question, but we do have about 40% of our patients with a perfusion index of less than 2.
Thanks very much for that.
Mm-hmm.
And just quickly, in terms of the outliers, I think we don't have specific plans to adjust yet, but most critically, we aren't going to eliminate any outliers before we kind of fully understand them, and wouldn't imagine doing that. And it looks like the other question has to do with the 4 categories. Yeah, in terms of the FDA statistical group, breaking down for equal categories. So since there's 36, would be grouped in clumps of 9 each. So that's what explains kind of the 4 categories. I hope that answers the question.
Thanks, Dr. Allman. Chris Allman from Stanford. We're having some name glitches in the Zoom, FYI. So everybody's names are pick your own name today, but keep an eye out for that. But thanks, Dr. Allman, for joining and answering. Just wanted to make a couple quick comments to the Stanford team. Would be, when you guys are able, would love to share the modifications that you guys have done for pediatrics. As you said, the adult protocols that we've been sharing certainly need modification, and you guys have made great progress. I know other teams would be interested. So we'd love to invite you guys to share that protocol, and we're happy to share it with the others when it's ready. On a related note, for others who aren't aware, there is a subgroup within Open Oximetry that are both conducting prospective clinical real-world trials right now. So if you're interested, that group meets separately. Please reach out to myself, Fifi, and we can add you to that mailing list. And then lastly, one of the things that occurred to me while Dr. Conrad was speaking was to Radical 7 and this issue of a lot of devices carry the same name for many years, sometimes many decades. And when we're talking about a device, it may not be the same device we're talking about. And this just goes out to the manufacturers, making it easier for researchers to understand which device they're testing, which device has different regulatory approvals. It's not easy to whether it's the 510K database or the device in front of you, but trying to figure out what is actually certified. An ability to look up via serial number what device you have and how it compares, I think is something relevant to the conversations that we're all having. So I just wanted to flag that as Dr. Conrad pointed out, that they're using a newer Radical 7. Many groups are using Radical 7s, but sometimes they're not comparable. Sometimes it's not easy to figure that out. So we can maybe discuss that later on while we continue moving through the agenda here. And from the Stanford team, Dr. Taneja, did you have any comments that you wanted to share as well?
No, Dr. Conrad covered it. Thank you.
Okay, great. Thank you very much for joining. We have 2 more speakers as we round out this particular panel. Oh, Dr. Coombson, did you want to, I see your hand, apologies. Did you want to ask a question?
If that's okay, can I ask one question? Oh.
Please.
Okay, great. Thank you. Thank you for the wonderful talk. And I just had one question about your data. And specifically, I know Pulse Oximetry is used as a newborn screening tool for heart defects. And I was wondering if as part of your study, have you looked at data in terms of how pulse oximetry testing and the various standards and requirements have the impact it possibly has on this screening tool as it relates to heart defects?
That's an excellent question. Specifically, that is not within the direct scopes of this project that we're working on right now, but it is definitely a clinical question that we have interest in further looking into. And I think when we get to the longer question and answer section, we can kind of talk more on about that thoughts on there, because we could really go deep into that. But as of right now, that is not the scope of this question, but we do have a large population of congenital heart disease within our patient population group.
Okay. Thank you.
Okay, and with that, we'll move on in the agenda here. Roots is founded in East Oakland, and through that, she's pioneered the delivery of culturally responsive whole health and championed the integration of physical and behavioral health. She also was part of a team that published a paper in the American Journal of Epidemiology on racial disparities in pulse oximetry recently, and we're very glad that she's joining the conversation. Thanks so much for taking the time. The floor is yours for comments, and look forward to hearing from you.
Yeah, thank you for having me. This has been a great discussion this morning, and I'll just keep it informal, just kind of describe how I came into this. I guess similarly to Dr. Schoeding was during COVID and during the height of COVID and early on, actually seeing some of the death disparities in many parts of the United States, but particularly where we are in Oakland, and seeing that we had about double the rate of death from COVID among African Americans compared to whites, and really wanting to understand what was going on there, because we were still seeing the disparity even after controlling for underlying conditions and socioeconomics and essential workers, et cetera. So we kind of kept on digging in and trying to just find out anything that we could about what could be going on with the treatment guidelines, where could some of these disparities be coming from. And we actually came across Dr. Schoeding's article, and then sort of set out to see whether this difference was creating any differences in treatment. And we did find sort of the confirmation, I guess, of systematic overestimation of blood oxygenation in people with darker skin tones. But we also were able to see, because of that, a lower probability of admission, lower or a delay to steroid or supplemental oxygen, and just an increased time to treatment in general. And I think, as you know, when I first even just came across Dr. Schoeding's article, I started calling all the doctors I know in, emergency medicine, critical care, pulmonologists, and so on, and really found that nobody had heard of this issue. And it felt quite devastating, especially for those of us who specifically have dedicated our careers to working in communities of color, eliminating health disparities, to find out that a tool that we thought was the subjective way to measure something so critical. And, in practice, we do think of it as like a fifth vital sign. And so even though, I hear, the guidelines around this is for spot checking or for trends and so on, we know that in reality and in practice, it's seen, in outpatient medicine, in, our emergency medical folks, on the ambulances and so forth, are really using it as a fifth vital sign. And the guidelines for COVID were very clear. And it was actually, pulse ox readings were the only objective measurement for how we were going to then disposition COVID patients. And so when we had, especially when we had shortages of hospital beds and oxygen and things of that nature, and you layer on this, this issue on top of explicit and implicit bias, and with shortages of resources. I mean, this is really just a recipe for disaster, and likely did contribute to disparities in terms of morbidity and mortality for folks with darker skin tones during this crisis. And we know that we use pulse ox for other things as well. We sent people home with them. I know a lot of patients who purchased them and have kept them at home in a box for a time when they get sick. And want to know now what am I supposed to do with this? Is this going to be accurate on me? And so the use is very ubiquitous. And I think that, I think the sort of train has already left the station as far as not using it for diagnosis and decision-making. That's already happening. Still have a lot of physicians that aren't aware of this information. And it's definitely, I think, leaving community as well as those of us who care for community in a situation of, feeling that we're seeing a contemporary example. We don't have to go back to Tuskegee. This is happening right here and now, where a really unacceptable situation around devices that do not work equally well across all skin tones, having gone essentially ignored for decades now. And, even now, since having it very clearly on display for the world in the past few years in the midst of this crisis, we still don't quite have a resolution. So definitely encouraged to see that we're getting together to address these things now. But in the meantime, I think this is, it's really important that we recognize we're in a very critical moment. I think this is an opportunity for us to show how we're going to do things differently this time, do things better this time. And not just name that we have a problem and then just keep going along with it. We're going to have to definitively address this if we're going to hope to regain trust. We hear about mistrust and needing to rebuild trust, and we hear about equity. But this is our moment to kind of actually walk that walk. And part of rebuilding trust is acknowledging that we have a problem that has gone ignored unjustly for too long, that has probably led to disparities in care and treatment. And it's, not just about COVID. This is how we determine if folks get home oxygen. There are a number of ways in which this actually does determine care. It determines whether Medicare is going to even pay for home oxygen. So I think we have to definitely be in reality about how these devices are being used, both the FDA cleared devices as well as the ones that are purchased across the counter. Physicians are still recommending that people check their pulse ox. If they catch COVID, check it at home. But there's no additional guidance here about, should I establish a baseline? How much should I trust it? What should I do? Is there a certain range where, I should be more skeptical? And, likewise, in terms of educating physicians and other healthcare providers who, where this news still has not made it. And we know that it takes time for these things. But really, this is a matter of some urgency, and we need to treat it that way, or we are missing an opportunity to kind of rebuild that trust. I think that, beginning to be transparent and honest and sort of, participating in a bit of a reckoning around this situation and others is going to be critical if we want representation in the clinical trials that we are going to need, if we are going to end up with devices that actually work equally well across all skin tones. And I hope it goes without saying, but we need devices that work equally well across skin tones. Period. So in the meantime, there may be corrections, there may be algorithms, there may be other guidance, but at the end of the day, what we need is devices that we can rely upon. But in the meantime, I think we need some honesty and some transparency about where we are, because I think that will underscore the importance of why we need people of all skin tones to participate in the trials. And that is so, so critical. So I think building some of those bridges, rebuilding some of that trust, remembering that equity is not just a word, it really has to be a framework where we center the people who have been the most harmed. And then we go from there. And so I think if we are able to do that, then what that looks like to me now would be, talking to folks in the community that I serve in East Oakland, making sure that they understand what has gone wrong up until now and what we intend to do to fix it. And how can we include them? How can we bring them into the fold? Because they have been the most impacted and the most harmed. And this is what we are trying to correct. And so I think, honest communication and dissemination of the information to both the healthcare providers as well as the communities that have been most affected is going to be really critical into this next phase. And thanks for the opportunity to participate today.
Thanks very much, Dr. Abalata. I appreciate you taking the time to join us and hope that you're able to participate in some of the conversations over the next 2 days. I'm sure you'll have a lot of valuable perspective and thoughts to share. So thank you again. We're going to move on to our final speaker for this particular session. We're getting back on time, so we will take a few-minute break after that. So hang tight. Up next, Dr. Louise Mulroy. If you want to begin sharing your screen as I introduce you, please go ahead and do so. Dr. Mulroy. Okay, great. Dr. Mulroy is an assessor at the Medicines and Healthcare Products Regulatory Agency in the United Kingdom, the MHRA, working in the benefit risk team, covering respiratory imaging and critical care in the safety and surveillance group. Thank you very much for joining us today. We look forward to hearing updates from the MHRA and from you and your team. Thank you. Over to you.
I hope you can see the slides now and hear me.
Yes, we can. Thank you.
That's great. Thank you for the opportunity to participate as well. Thank you. So I'm just going to give a quick overview of the work MHRA is involved in relating to the potential for inaccuracy with pulse oximeters with different skin pigmentation. So firstly, I thought it'd be good to have a brief introduction to the MHRA with the Medicines and Healthcare Products Regulatory Agency. So we're the regulator of medicines and medical devices and blood products in the UK. We're an executive agency sponsored by the Department of Health and Social Care. So we undertake market surveillance of medical devices in the UK, and we're the designated authority that administers and enforces the law on medical devices in the UK. Additionally, we're responsible for the designation and monitoring of UK conformity assessment bodies. So these are independent third-party assessors of the manufacturer's pre-market compliance with the regulations. So to give some background, I thought it'd be useful to mention that in early 2022, the UK government announced there would be an independent review on the equity of medical devices to advise the government on health impacts of potential ethnic and other biases and to make recommendations for more equitable solutions. So this work is ongoing. MHRA is involved in inputting into this, but we are not leading or coordinating this review. So there's 3 strands of work MHRA is involved in relating to the effect of skin pigmentation on the accuracy of pulse oximeters. So in March 2021, MHRA published guidance on the use and regulation of pulse oximeters. This was published on the gov.uk web pages, and this has a link here which I can put in the chat if that's helpful. So this guidance highlighted the possibility that patients with a lighter skin may have small differences in the result reported compared to those with darker skin, in the context of this being one of many factors that can affect pulse oximeter readings. And it advises that the relative change in a patient's reading may be of greater significance to clinical management than the absolute value. And it does provide advice for clinicians interpreting pulse oximeter readings. Oops, sorry. So in terms of regulatory activity, there is work underway to develop the new UK legislation, and there will be opportunities to address bias in a wider sense, not specifically relating to pulse oximeters. In the published government response to the consultation on the future regulation of medical devices, this indicates that it's one of the 5 pillars of the future UK regulations will be built on, is addressing health inequalities and mitigating biases through medical device product life cycles. The results of the consultation indicate support around conditions which must be met when performing clinical investigations, and for stricter requirements for devices which can use clinical data from an equivalent device, which would help to improve the evidence base for these types of devices in the future. Currently, MHRA is reviewing the post-market evidence around pulse oximeters safety in relation to ethnic bias, and we'll be seeking expert input from our interim devices working group on this evidence and potential risk mitigation actions. So MHRA is not currently aware of any reported incidents of harm resulting from bias or inaccuracy of pulse oximeters with differently pigmented skin. However, we are aware of a growing body of observational studies concerned with this issue, and there's biological plausibility of this effect. Just thought it might be useful to highlight some work and publications by other organisations excuse me, in the UK relating to pulse oximeter safety. In December 2018, a patient safety alert was published by NHS Improvement about the risk of harm from inappropriate placement of pulse oximeter probes. And also there is guidance on the National Health Service web pages on the use of pulse oximeters as part of the COVID-19 response. This specifically has a section on a patient having brown or black skin, which you can see here, and advises to check oxygen blood levels regularly to see if readings are going down. So thank you again for the opportunity to participate. That's a very quick overview.
Dr. Mulroy, thank you very much for joining. We appreciate you taking the time. If you are able to, if you could share in the chat any of the links to the documents that you referred to, we'll be sure to put those into the meeting agenda and also put onto the community resources page that we're trying to maintain.
Yes, will do.
Thank you so much. Thank you to all of our speakers thus far this morning. I don't see any comments immediately to address. So at this point, we're going to take a 5-minute break and we'll be back online in about 5 minutes.